another great session. It was an excellent topic so far. We covered valve and live transmission, and finally a great panel discussion over the Medtronic valve. So with this, we'll move on to a dual knowledge session. It's a great pleasure to have Beirut Valve and our colleagues from AG Valve to have a joint session together. So it's my honor to invite my dear colleague, Dr. Ziyad Ghazzal, Dr. Ahmed Al-Jindi, Dr. Yasser Sadiq. So I want you kindly to join me, and Dr. Fadi Sawaya is supposed to be with us here, but unfortunately for last minute he couldn't make it, so he made a recording of his presentation 10 minutes ago. So he'll be the only person allowed to be virtual with us. Okay, so we'll start again. So our program will involve life in a box and cases between the two societies. So again, my honor to introduce Dr. Ziyad Ghazzal to present his life in a box case.
Let me see if I have the right slides here. Don't open the live in a case yet. Close this, please. Open there is a slide set first. Not this. No, not this one. Close it. I told you there is a slide set that comes. So close this one, please.
So while Ziyad gets his slide deck up, thank you fellas for the invitation. Always lovely to be with you, and GI as well. So I think the theme, Ziyad, we chose for the session is coronary obstruction. So either identifying high-risk features for coronary obstruction and different ways to prevent and to manage acute coronary obstruction should it occur. Yeah. And I think Ziyad is going to take us step by step.
Thank you. So this first case is live in a box, and then we will move after that to the topic of coronary obstruction, but this one is not related. It's just a live in a box, a nice case that I did with Dr. Sawaya. So we're going to share with you this case of an 8-year-old gentleman who has a history of shortness of breath, dyspnea on exertion. You can see from his EKG that he does not have any conduction system abnormalities. On echocardiogram, he has a normal ejection fraction with an tight valve, aortic valve area of 0.8 centimeters square. Gradients, peak mean is 80 peak and 56 mean. And you can see this from the echocardiogram. The pre-planning TAVI-CT shows a large valve with a perimeter of 86 millimeter and an area of 564 millimeters square. You notice that the sinuses are big, and the STJ is also big with a perimeter of 100 with a min-max of 33 by 36 millimeters. The right coronary artery height is generous at 16 millimeters. Left coronary is acceptable, 12.6 millimeter height. These are the angles, the classic cusp overlap view, usually in ariocaudal, as you see here, and the implant view. The three-cusp view is usually an LAO-cranial view, as in this patient. A very, very calcified valve, and the anatomy of the iliac bifurcation and femorals is very acceptable. You see the calcifications at the aorto iliac bifurcation, but it's not really compromising the lumen in any significant manner. So this is a case that where we'll be using a transfemoral TAVR with conscious sedation, of course, ultrasound guidance. Because it's large, we plan to pre-dilate with a 25 millimeter balloon and pace over the wire. We're going to be using the Accurate Prime 29 millimeter, which has some features: better radial force, better markers, and better deliverability. Even it's something that you can. It's a device that you can pull back through the sheaths should you lose the wire, because the original Accurate could not allow you to do that. And of course, we're going to demonstrate commissural alignment. The equipment consists of a 14 French eye sleeve, which is actually quite user-friendly. The transfemoral delivery system consists, as you know, of two rotating knobs. The first one, number 1, where we turn the knob very, very slowly, first to allow the upper crown to expand and catch the leaflets, and then we continue turning knob 1 to allow for the stabilization arms to open up. That's all very slow turning, as we will demonstrate. And then once we're satisfied, we remove the safety knob and turn knob number 2 very quickly. In fact, knob number 2 now with the Prime is, with the Prime is better designed. With the original Accurate Neo 2, we used to turn a few turns to open very quickly to open the lower frame, but here all you need to do is turn 90 degrees. So it has this stabilization arm. The nice thing about this valve, as I said, it allows for equally distributed radial force through connected cells. And it's a supraannular leaflet design. The commissural alignment, perhaps I can show it better on the view. So it has plenty of markers, especially one at the bottom that you don't see well on this, that you don't see on this crowded slide. But bottom line, if you just look at this slide right here, I don't think, let me see if I can. Okay. So just look at this commissural alignment here. In a three-cusp view, what you need to see is that the 3 posts are symmetrically displayed, as you see here. One in the middle, one on each side. On the cusp overlap view, this being here, the overlap of the right and left cusp, on this view, you're going to need to see 1 post. And it's easy to remember, because if you think of 2 cusps overlap, you want 1 post to be facing. If you have 2, that means you're blocking the 2 cusps where the coronaries are coming out. Okay, so you need to be, where you have cusp overlap, you need to see 1 post, as you see here. And on the back, on the non-coronary side, you're going to see 2 posts. So without further ado, I want to, if you can move to the video, please. Are you guys with me? Can you move to the video? Any comments so far? Okay.
Waiting for, I just wanted to, I haven't used the Prime platform so far.
Okay.
So what are, I haven't used the Prime platform.
Yeah, so it has...
what are the differences here?
It's, so the Prime platform, it has really several, it's a bit more deliverable. It has better markers that we will demonstrate at the bottom. It has better radial force because it has this cell connectors. The knob 2 is more user-friendly. You don't have to turn, because this is important as you want the lower frame to expand very quickly. you don't want to turn several times. So here you turn only 90 degrees. And then one advantage, as you know, with the classic Neo, you cannot, if you lose your wire and you want to pull back your catheter into the sheath, you cannot do that. But with this one, you can. So just for the sake of time, I'm going to cut a little bit. So go ahead and start it, please. I may just cut through it. Do I move it from here or? Okay.
Here with my colleague Ziyad Ghazzal. You know him. We've done a lot of cases together with the Accurate platform. We have a very interesting case, mid-80s-year-old guy. He has severe symptomatic aortic stenosis. We looked at the case before. He has a large annuli with a pace anymore from the needle. I'd rather have a wire. If patient goes into heart block, I directly slide a sheath, and then I'll put a pacemaker. And I have a 8 French here sheath. We use 1 ProGlide. Our practice is 1 ProGlide when 30% of the cases, or 20, will add the 8 French angio-seal. What we've done so far, we didn't do an angio before, so we did an angio today.
I'm going to skip through the coronaries.
Here,
he has some disease, but just for the sake of time, I'm going to cut through this.
And we have a very severe aortic stenosis with a peak-to-peak of almost 80, which we knew from the echo. The mean gradient is 60, and on the CT, the leaflets are very calcified. So we're now, I'm here, this is live, I have a pigtail, and that I'm gonna put the Safari on, and we're gonna start the case. I do an aggressive predilation with a 25 balloon. We'll see if we do 1 or 2 inflation, and then we'll show you the new feature of Prime and what's special about the XL as well. Okay, here we're putting the Safari wire. This is Safari small. It's pointing well, and we're at the outer curve. And that's also a very important thing to do with the Accurate valve. Now I'm gonna put the 14 French eye sleeve. So we're gonna get the sheath, not give a lot of contrast.
Yeah, I'm just skipping through it a little bit.
But that's an advantage over the old Neo2 system.
So the advantage that Fadi was mentioning is what I told you, that you can retract
robust radial force, more distributed radial force
through the sheath if you have to.
And also a better seal for...
Okay, so here if you see he did the left bundle directly after the wire, that's never a good sign. And he's going back between left bundle. So this is also a sign that this patient has a very compromised bundle. And we're going to pace over the wire like most of our cases, and we're going with a 25 millimeter.
And with the Accurate, you can pace over the wire. I mean, because the pacemaker is not as essential as with balloon expandable valves, for example.
So just for the sake of, who in the room uses an Accurate, either a Neo or a Prime platform? What? So a minority. So you might want to just shed some light on the technical details, because you said it very quickly with the wire, and Fadi mentioned it, having to sit very comfortably on the outer curvature of the aorta. Yes. But can we please, as we go, Ziyad, because apparently not many people have experience with Accurate.
So as far as the outer curve, I mean, it's always important to sit on the outer curve and this has to do with how you push your valve and how you maneuver with the wire to be able to sit on the outer curve so that you are a bit more coaxial with the deployment. I think I lost the...
So the difference with the Accurate compared to virtually any other self-expanding platform we have on the market is it is released upwards, so it's up-bottom rather than bottom-up. And the initial part the valve has to be delivered when it's completely resting on the outer curvature of the aorta. And if you fail to do that, you stand a very high risk of popping the valve during the second stage of release. So the initial stage where you release the stabilization arches and the upper crown, you'll see that Ziyad and Fadi will make sure that the last movement is always towards forwards. Backwards. Yeah. Even if they have to adjust, if they went too deep, they will go back all the way and re-advance it So the forces have to be forwards before you start release.
Yes.
And I think that this makes accurate one of the preferred valves in a horizontal aorta, especially because of this pattern of deployment.
It's a very,
And also
I
a
would say,
better
flexible
seal
system.
Okay, so here if you see, he did the left bundle directly after the wall.
very
I
calcified
think we may have missed the, I
Remote
think
valve.
it's important to show the three-cusp view with the two
Find that.
catheters.
and also a better seal for
Okay, the old Neo2.
Okay, so we do balloon, couple of balloon
Okay,
inflation.
balloon up.
The first one slips. We put it in a better position.
Balloon
and the
up.
second one works well. That's a 25
We're
millimeter
gonna do it
balloon.
one more time, just let the patient breathe.
Okay. So you see a good expansion, a lot of calcium, as you can tell. And we
All right,
saw that
Hassan,
from
can
the
you-
CT.
The balloon is not going into the sheath, also it was deflated. This sometimes happens, we're gonna have to remove it all as one unit. Hopefully we won't have any vascular complications. So here we're introducing the prime XL valve. As you see here, there's like a commissural sign that it's not at 6 o'clock anymore. So you just follow the commissural at
So
12
basically,
o'clock, okay?
Ahmed,
this
there is
needs to
this
be up.
marker
Needs
that
to
we
be up.
put
Okay, so now we're gonna go and we're
superiorly,
gonna then
this
go for
one
the
marker.
commissural
Remember, it
alignment.
was a
So
6
I'm going
o'clock
slowly with
on
my
the other
sheath,
one. This
with my
is-
valve, I mean.
It's compatible with the eye
Okay,
sleeve
and Ziyad is
sheath.
gonna make sure he's tracking you well.
Oh, yes,
All right, I'm inside the sheath, some minor resistance. All right. It's a very trackable system, as you guys know. We're gonna try to stay on the outer curve.
So Ziyad, we'll give you a
All
couple of
right.
minutes
And
just
here
to
I'm gonna
explain
try
the
to
commissural
adjust.
Need the
alignment
laser,
here.
can we have the laser pointer here? فينا نجيب ال...
So now you have the additional 3 markers at the bottom.
I want you to be able to appreciate the 3 markers at the bottom. I have it
Give me
here,
a
but it
wire,
doesn't
please.
show. هيدي ما بتمشي.
واير عادي بيمشي الحال.
So here I'm gonna do a cine.
Yeah.
We're in the 3-cusp view. What we see is actually the 1-1 configuration.
Yeah.
You see at the bottom, the wire is going through the middle marker. You have 1 marker on the left and 1 marker on the right. I'm gonna go to my commissural.
So it's a bit difficult to see those tiny little markers. I'm pointing them here on the screen.
The central one by now is
Yeah, the central one goes basically on the 3-cusp view. This here, we changed the angle just a little bit. So let me go back to that. And I think it's important to understand that here. That's better. So again, it's going to be hard to see, but 3 tiny little marker, 1 right overlapping with the wire, and then 1 to its left, 1 to its right in a 3-cusp view. Okay? And on a 2-cusp view, where you have the 2 cusps, meaning on the right of the screen, you're going to see 1 marker. Okay? And on the left of the screen, you're going to see 2 markers. And it's important to understand that for the commissural alignment. So let's see what we...
Configuration.
Yeah.
You see at the bottom, the wire is going through the middle marker. You have 1 marker on the left and 1 marker on the right. I'm gonna go to my commissural cusp overlap. I'm gonna do a cine. And what we see is 1 marker on the right of the screen with the commissural post on top, and then 2 on the left side. So we're commissurally aligned. It took us literally.
Okay, so even here, forgive me if I'm insisting on this because it's important. Even here,
Cine.
you don't have to look
And
just
what
at
we
the
see
marker
is
at the
1
bottom.
marker.
Okay, so again, it's a bit hard to see, but even if you look at the posts on top, above the central marker of the valve, up the top, the posts on top are easier to see, where you will see 1 to the right of the screen and 2 overlapping on the left of the screen. Okay, those of you...
Dr. Ziyad, just to make it more for discussion,
Yes.
we just, if you move to the final, then we'll
Yes,
we need
yes,
to
yes.
present other cases.
Absolutely. Okay, so
On the right of the screen with the commissural post on top. Now we have to be very sure. There's 2 things we are gonna look at.
and here we deploy the valve using
Inject.
knob 1 very slowly. We're happy
I
in
think
this
that's a good
position.
starting
You see
point,
how the
right?
marker
Here's
is at the
pacer.
bottom
Let's
of the
pace at
cusp.
120. I like to pace with the XL. I see there's like more movement.
Okay, so we start.
We turn the knob one
this is a
very slowly.
gentle, slow
And pace at
rotation.
140, the pressure is still high.
Very slow until the upper crown.
You see here the
until we
upper
see
crown.
there we go. So now I stop.
Okay. We're gonna
Okay,
take an
you see
injection.
the upper crown. And then we
Okay.
keep turning the
I'm
knob
above the
to
leaflet, that's
release the
pretty sure.
stabilization
I'm
arms.
just gonna give it a tight advanced
Forward,
movement.
catching the leaflet.
Okay, you're gonna start going up more.
So now we're going to go again very slowly to
So look
allow
at
the
here, look at the
stabilization
stabilization arms.
arm to open up gently. This is again a slow step. So all number one is slow.
And you can see how the leaflet is sitting below the upper crown.
You see the stabilization arms.
So now you see the stability, and it's almost commensurally aligned, probably within
I'm
30.
gonna adjust a bit of parallax.
Yeah.
Inject.
So now we're going to
Yes,
deploy
Yeah,
the
so let me
lower
advance
frame.
a bit more.
And now the nice thing with the prime is that number two is quick, only 90-degree rotation.
All right, let's do it. 180 pacing. Okay, 1, 2, 3, goes yet. All right, perfect. Off pacing. I think it landed beautifully. All right.
Okay. So now you're going to...
All right, no hard block, which is good. The QRS is slightly enlarged, but that's fine. What I'm gonna do is I'm gonna make sure I remove my nose cone very gently. I wanna make sure I don't catch on anything. All right. And now Ziyad is gonna do 2 and 1.
So two first, so I'll go counterclock on two, and then one.
So now we're retracting, closing the system on itself
All
so
right,
that
you
we'll
can
be
go to
able to
full
pull it
stop.
Yeah. That's a full
from the
stop.
sheath.
Okay, so now we
Now make sure there's no, give me a pigtail just so we can remove all these ectopy, and then we'll see if we need post dilation. You have it? We don't see any bending in the posts.
yeah, so no parallax.
All right, so we're gonna go, no bending is post, there's no mud expansion. But here, we see that the valve is taller than it's wider.
So it's taller
that tells
than
me we're
wider.
underexpanded. So I'm gonna take another 25 balloons, and we're gonna expand with 25 balloon. If it doesn't work, I'm gonna take a bigger balloon. Unfortunately, I don't have a 26, so the next size is gonna be a 28. And here in this view, if you look at the top, the second post is bent.
The central
so we're a bit
post
underexpanded.
is not
so we're gonna
aligned
take
with
back
the
Safari.
two other posts.
Although we have no gradient. If you look, there's no gradient, Ziyad.
Yeah.
But I'm still not happy with the bending of the post, and the valve is taller than it's wide, okay? So we're gonna re-expand this valve with this 25.
So the
If I feel it's
configuration
still
of the valve, the
underexpanded,
way
I'm
it
gonna
was
take a 26
deployed
balloon.
is not ideal, so we
Can I
had to
get
do
a
a bit
28
more
balloon?
work.
Can I have the Safari, please?
So Ziyad, sorry, for the
So
sake of
even
time.
if you're...
Yes.
Can we see the final
So we
result?
do the final balloon
And you don't see the
dilatation.
bending, I'll show it.
As
Can
you
hold
see
the sheet
here.
for a second? So the gradients are really good. We can take our last balloon
This
down.
is the final balloon dilatation.
can result in
And
stent thrombosis, in
leaflet
valve.
And it needs also post
And we
dilation.
have a
On the
squared, much better
left side is
appearing
now straight.
valve. And the final gradient was 6. Okay, that's it.